Hi, good afternoon, everyone. This is Andrew Bluestein, Vice Chairman of Garfunkel Wild. I want to thank everyone for joining this afternoon. We have a huge turnout, and it's not surprising given the topic and the speaker. Before we start and I introduce John, I want to give a shameless plug because this webinar is being hosted by the New York Metro ASC Symposium. This year it is on November 2nd. It is at the Marriott Marquis in the center of Times Square. We are having a great turnout, both for sponsors and for speakers and attendees. And the purpose of the seminar is for everyone to come, learn. It's a one-day event followed by cocktails if you're so interested at the end, and it's on a Friday, so then you can go enjoy the weekend in Manhattan. We have heard, and I'm looking at, there's a lot of new faces that are joining this. We have heard a request by nurses and administrators that they want to come, they do come, but they would like to get credits. We have both applications for nursing and administrative credits pending. I have no doubt that we'll get them, so assume that to be the case. And the New York Metro ASC Symposium is a joint product of Garfunkel Wild, my law firm, and Priority One Group. Now, what we're doing in recognition of John and JDJ Consulting agreeing to do this is we're going to offer a discount over the next 2 days if you register. To do that, and we didn't put this on the slides on purpose, you should grab a pen. The discount code, you'll put it in on the website, is NYM, which stands for New York Metro, NYM 18W. So I think it's a $75 discount, and feel free to use it over the next 2 days, but you don't want to wait that much longer besides for the discount because we are filling up. Again, it's NYM 18W, and you can register by getting on www.newyorkmetroasc.com. And that is this shameless plug. And now I'm going to introduce the topic and our speaker. And the topic is narcotic, diversion, and risk assessment and prevention. It is, and we were talking before with Brittany and John before we got together, this is an extremely important topic. I just saw this morning that 30,000 overdoses from opioids happened in 2017. So it is an issue that is plaguing everyone. And from the legal aspect, we see it all the time with nurses who get into trouble and physicians and ASCs. So it is very timely. And we are thrilled to have John Kowalski, who's the president and founder of JDJ Consulting, to be our speaker. John earned his degree as a pharmacist at the Philadelphia College of Pharmacy and Science and his MBA at Drexel. And he began as a pharmacist and then with all good people started to grow and became the director of pharmacy services at Graduate Hospital in Philadelphia. And John has spent his career dealing with these issues and medication errors. And then he began to focus when he founded JDJ Consulting in 2001 on the ASC world, given everything that they deal with in these and other similar issues. And so from a few ASCs, he's now grown to 4 states and 200 ASCs and 4 hospitals. So he's a very, very busy person, and we are completely happy and thrilled that he has agreed to be our speaker today. And so, John, take it away.
Thanks, Andrew, and thanks for everyone to join in today on my topic. I do want to thank Andrew and the New York Metro ASC organization for inviting me to speak to the group. I really want to have something that the listeners can take back to their facilities, educate and further educate their staff. One of the things that is important, and what I see as a pharmacist, is that we want to make our ASCs the safest possible for our patients when they're coming in for surgery. And narcotic diversion is something that I'm involved with way too frequently in helping centers deal with potential diversion issues and risks of this nature. So today I'm going to give you some tips and some ideas on maybe sharing best practices that you could share with your staff. To start off, an alarming statistic is that 10 to 14% of healthcare professionals may have an addiction problem to illegal substances, which is the same percentage as our general population. Quite alarming to know that 1 in 10 of our healthcare workers may, in fact, have an opioid addiction, and working with and caring for our patients throughout this country. It does cost our society billions and billions of dollars every year to control this problem. And the most alarming statistic that I want to share is the risk of our patients with bloodborne pathogen infections as a result of a healthcare worker diverting these types of drugs in our healthcare settings. Very alarming that, and this is the message that we need to get out to all of our healthcare workers, is that our patients need to be safe. And hopefully some of the tips today you can share and be more aware of risks at your facility if they do present themselves. Well, we want to define drug diversion. It is the transfer of any legally prescribed controlled substance from the individual for whom it was prescribed to another person for any illicit use. This can include missing narcotics at your ASC. We never want to just say at the end of the day when there's a discrepancy with the count that, oh, it might have got lost, well, we'll save it for tomorrow, we'll fix that tomorrow. It really needs to be addressed. Any missing narcotic could be a form of drug diversion. Staff member using narcotics, we're going to talk about red flags and how to identify concerns that you may have your healthcare workers at your institution. Stealing narcotics, we don't want to be an industry. I think we have an opportunity with our ASCs to be a leader in fighting narcotic theft and having our drugs on the streets for illicit use. And then, of course, the DEA is working very hard at identifying physicians that overprescribe narcotics. And we're going to talk a little bit about the states and the federal government's actions in this area of drug diversion. Why is it happening? Well, many reasons force a healthcare professional to move into illicit drug use. Self-medicating for pain or health issues, supporting an addiction to an illegal substance, inability for someone to manage their stress from work or personal life, and possibly someone trying to resell these on the street for a lot of money, and the theft in your facilities is at risk. Those with access to these drugs are more likely to divert. So again, we have to be aware of who's in the continuum of these medications in your facility and have the proper checks and balances to ensure diversion is not a risk. How is it possible? Well, we know in the reports that narcotics have been replaced, taken for personal use and replaced with saline in a vial, and then that saline given to a patient, splitting vials, giving half a vial to the patient and administering a partial drug to the healthcare worker. Documentation is something that I really want you to go back and begin any type of surveillance or audits on proper documentation. We have found numerous opportunities to prevent diversion just because we've worked hard on making sure that everyone in the facility is documenting narcotic usage correctly. That pertains to the dose administered in the chart, to the co-signatures for any wastage that might occur, And this is really something that I want to drive home to all of us today listening in. Well, it's affecting healthcare because so greatly that the DEA has rewritten their regulations. They're forming task force and finally offering additional training to healthcare professionals. The DEA's focus for many years was combating illicit drug, heroin, and cocaine coming in from other parts of the world, but now their focus has turned to our United States and controlling illicit drug use here. States have begun numerous programs to control the number of days of narcotics written by surgeons after surgery. They've also requiring education about take-back programs, which I'll talk more about in a second. Pharmacists are required to determine if patients are drug seekers when they walk into the pharmacy with a prescription, and the pharmacist's obligation to research the prescriber to determine if their patterns of prescribing are something that needs concern or reporting to the DEA about. I really think, I was talking to Andrew earlier before the talk about pain management options, and I am seeing that in many of my surgery centers in talking to anesthesiologists, surgeons, changing to anesthesia, giving more blocks for pain after surgery, changing to various non-opioid modalities. If anybody is doing joint replacement surgery, you know that the pre-medication TLC or Tylenol, Lyrica, Celebrex is very popular, in addition to some opioid short-term pain medicine. On cue balls, Exparel, a lot of things are happening with pain management after surgery, which I think is changing the paradigm in how we use these dangerous opioid medications. So ongoing efforts to prevent diversion, as I said, start with the DEA offering conferences to pharmacists, which I've attended one down in Baltimore, Maryland last year. Surveyors also, Department of Health surveyors also asking if staff is receiving education about diversion prevention. I continue to speak about this at my centers throughout the Mid-Atlantic states. Be glad to offer that at any of the attendees listening today. Just yesterday I did a talk and it was very well received about staff, and staff are very enlightened about when we talk about risks for diversion right in their facility and what it means when a cart is left open, what it means when documentation is incorrect, what it means when a red flag of a fellow employee is identified and not, reported upward to investigate further. Really, staff education is a great part of this prevention program. Diversion coalitions at the state level are occurring. New Jersey has a coalition for our narcotic diversion, and they meet annually. I was a speaker at that meeting in June. Emergency opioid restrictions, prescribing restrictions is getting tougher and more in line with how many days of medications these patients do really require after a procedure. Didn't mention there was the dental industry has data to show that instead of prescribing Vicodin post-dental procedure, patients that would take Tylenol and an NSAID like Aleve or Motrin together, 4 to 6 hours, will have the same pain management effect as taking an opioid. So that data is tremendous, and it's being presented to our dental societies around the country. Let's focus on the next subject, and that's suspecting diversion. It may be something you found or a suspicious event, something that an employee is showing behavior-wise. Maybe it might be empty containers found outside the normal area, bathroom or trash. I give you slides here that I have personal examples of when being called as your consultant pharmacist that have taken place. So I'm sharing real life stories that resulted in further investigation and prevention of diversion. Anesthesia providers turning in too few or too many vials, inconsistencies with their count records, And suspicious behaviors is something that we can't overlook when we're talking about this subject. Red flags certainly are something that we all want to know about and speak up about. Doesn't always mean that diversion is occurring. Multiple occurrences, especially by the same individual, should, and certainly require careful investigating at the highest level. So what are some of the behavior red flags we're talking about? Possible frequent disappearances, bathroom breaks that are excessive, not knowing where someone is, unexplained multiple sick times or absences. Here's one: excessive time spent with drug stock, volunteering to work with controlled substance stocking, maybe unpacking, inventorying, retrieving doses for the OR. I had a surveyor tell me that when a surgeon uses morphine in the OR and the nurse just goes to the narc cabinet and brings out the vial, that the paper trail by the surgeon signing for that should be part of that transfer. So again, looking at what you're doing in your facility and looking at risks is important. Performance, work performance alternates between extremely productive and unproductive, and the mood swings are certainly something that would stand out as a red flag. Confusion, memory loss, all of these things. I'm not going to go step by step, but I want you to pay attention to this list, and I think it's adding even another page. This is in the literature, or things that I have been called to help with. So paying attention to the red flags is something that could benefit you and your staff by keeping an eye on. So you think there's diversion at your center, now what? Okay, you've done some investigation. You've been told about something that's occurring. You have an unresolved discrepancy. Before we get to the next slide, I really want to make sure and highly recommend that you have an internal policy that you can turn to immediately if you suspect diversion, so that you are following something that's been approved by your legal department or your attorneys or your governing board to allow you to follow steps that wouldn't prevent you to moving forward in eliminating a potential problem. You want to have the backing of everybody once you begin a process of investigation. And a policy really is something that we have all of our institutions. So also, it begins with you keeping good records of everything that you've been told, everything that you've seen, everything that you've investigated, every interview that you've made with staff. These records and your documents will come in very handy down the road if questioned about a situation that you were dealing with. When you don't write it down, that's when you forget. You forget the time frame. You forget the person you talk to. You forget the actual response by the individual who you talk to. So document at the very beginning, even if it is not taking you down a path of diversion. You can always just get rid of that document. But definitely recording these events is paramount. How to proceed would be certainly something your consultant pharmacist should help with. Reporting any suspected diversion, theft or loss, or an individual caught diverting is something that the legal authorities would have to be involved with, different professional boards, DEA, and you want the guidance and the proper plan in place. This is, again, after you've exhausted every opportunity to find a missing drug or you've ruled out a problem person. Also, you want to, before you begin your testing of individuals, know that legally when and how you can require that. I've had varying stories of one facility manager having diversion, testing every employee that was in the building immediately, to others not testing anyone. We recently did a diversion assessment benchmarking study for our accounts last year to look at best practices, and it was very varying on what centers allow urine testing or drug testing for suspected diversion problems. So clear that up with your center, and certainly we'd be glad to help with that activity in determining what steps you want to take in diversion suspicion. Reporting, again, I said, is something that is different in each state, and the authorities that you need to report to have to be done in a certain time frame, and reports have to be kept intact. So understand in your policy the steps that need to be taken there. Notification of the various agencies, again, another slide on DEA, local field offices. If your state has a CDS department, Department of Health, maybe your Attorney General, on and on and on, based on your specific needs and requirements in your facility. So let's talk about the patient and the impact. And the biggest concern I have as a pharmacist representing and consulting with surgery centers, and that is a patient, could be your parent, could be your relative coming in for surgery, and as harm is done to them because of an impaired employee. Impaired employees can give partial doses of medications to a patient, give no medication at all to the patient, and run the risk of infection of a patient just by using that needle on themselves in the workplace. So we really have to be extra careful and have our patients at the paramount. Here's an example of infection risks with 2 healthcare workers in various parts of the country injecting themselves or contaminating vials that were then administered to patients. And hepatitis C was identified in 2009 with a drug diverter on site. Here's a slide from '83 to 2013 on outbreaks in the United States from drug diversion from a diverter in healthcare. We do have a duty to report. Ambulatory surgery centers have a legal and ethical duty. Failure to report can result in liability, negative publicity, jeopardizing the surgery center's license. Failure to report puts additional patients at risk. We had a anesthesiologist turn himself into drug rehab after we identified some risks. And the CDC was, the Department of Health required the facility to contact CDC for fear of possible patient contamination from, contaminated needles maybe being used. And releasing a diverter from employment without reporting is illegal. So know what the laws are with reporting diverters. We're going to go through some strategies for preventing and I'm going to give you some examples of tools that we use in our facilities, and our facilities use them on their own throughout the year and report this data up to their safety committees or to the committees that require information about compliance with narcotic control in their facilities. Number one strategy is the controlled substance inventory continuum. All the steps along this path, from when the facility places an order to when the medication is administered and then wasted or disposed of, should be something that you are looking at or observing or monitoring. Every step along this continuum has ended up in diversion, and I've been involved with diversion that occurred in every one of these steps. So I think this is a tremendous slide. I did fail to tell you that the handout is available on the sidebar if you wanted to print that out. It's a PDF form to follow along. My bad. Andrew gave me such a wonderful introduction that my head was getting too big to talk about the GoToWebinar handout available. But anyway, this slide is available. I think it's a great one to print out and ask yourself and your clinical team and your governing body that are we comfortable in every step in the controlled substance inventory continuum? Because I can tell you, if you're not looking at all these steps and you're not monitoring steps and you're not feeling safe about these steps, that's where the risk can develop. How many of these steps are performed by the same person? Okay, is your buyer for controlled substances the same one that's receiving the packages in? That should be a no-no. Two different individuals should receive controlled substance orders in, different than the individual placing those narcotic orders. How are orders for controlled substances being audited after they arrive? Are you doing any monthly audit of DEA orders versus what's been signed into your facility? If you're not, it's a good opportunity to begin that monthly screening. Are you closing the loop on your DEA 222 forms? There are many people that have moved to the online narcotic ordering, the controlled substance ordering system, or CSOS, but many of our smaller surgery centers still use the triplicate form for ordering narcotics. They need to be audited, monitored, and ensure that they're accounted for and the quantities received into the building are signed in properly. A few steps just on the continuum that I would recommend you go back and think about beginning if you're not already doing that. Purchasing audits, again, comparing what was ordered to what was signed in, should be performed by receiving audits. Audits can be done by individuals from different areas of your facility. We want to have different levels of auditing from upper management down to the staff nurse so that it's all not under one individual. Are your DEA forms stored and secured properly? If you're using CSOS, it's a great opportunity to store this data right on your computer and have it readily retrievable. This is an example of a daily count sheet for those centers that are manually counting controlled substances and are not at the advantage of having automation such as Pyxis or Omnicell. Paper-driven count sheets is what I typically see, and this document is the main cabinet, and two nurses count in the morning when you open up. They issue out throughout the day to the different operating rooms or the CRNAs or anesthesiologists. And this count sheet is a perpetual declining inventory of your narcotics in your building. And this needs to continue on and be secured. Some facilities have these bound by a printer so that each page cannot be altered or taken out. These sheets should be secured at the end of the day in your locked cabinet. We had a facility call us, the owner, the surgeon owner, found a director of nursing diverting narcotics. She stole the whole count book, and there were no records to see what was missing and what was in the building for the last 6 months. Very bad situation that resulted in a lot of stress for everybody. This is a sheet that we use in a lot of our centers that the anesthesiologist receives their medications, their controlled substances in the morning. A nurse and the anesthesiologist or CRNA sign for this slip with their drugs. They go to their OR, they secure it in their OR cart, and they document each dose of controlled substance by patient procedure on each line. There's an area for wasting narcotics, and at the end of the day, they need to reconcile with one of your nurses to ensure that it is properly completed and there are no discrepancies. Very important to have the transfer of narcotics from when it leaves your main inventory count to another provider. 2 people sign off that transfer. That is really going to protect your facility. If that anesthesiologist or CRNA just walk off with 10 fentanyl and 10 Versed in their own sheet, and then they come back and say, oh, well, I only took 5 and 5. You didn't give me 10 and 10. You know, there's a lot of pointing fingers when you don't have 2 signatures. And then at the end of the day, reconciling that sheet before that provider leaves for the day should be performed with one of your staff members to ensure that it is accurate. We can't neglect doing this on a daily basis. We cannot say, we can't say, the CRNA drops their sheets off and they run out the door, we don't see them again. We have to set our guidelines up the way your facility needs to control these drugs. And if you have non-compliance with a contracted service, you need to make the conversation begin with the contracted service performing properly at your facility. Here's a form that you can use. A lot of our centers do an anesthesia audit each day of the month. In each OR, someone observes whether at any time of the day they walk in to see if the room is not in use, is the anesthesia cart locked? They're going to say yes or no. Were there any open vials in the anesthesia cart? Because that is a new CMS regulation that any injectable drug is single patient use. Were any syringes left found in the anesthesia cart at the end of the day? And this center is actually checking succinylcholine or rocuronium, not a controlled drug, but this is an audit tool that you can structure any way you want, and it's performed daily. And when you go at the end of the month to your safety committee or your other CQI committees, you can show compliance by each provider that manage their room throughout the month and go after areas of non-compliance. Here's another audit tool that we suggest being performed by you and your staff on the medical record and what was administered in the operating room versus the sign-out sheet. Basically, this takes 10 charts, random charts. They put the medical record number, what medications were administered, did it match the chart, yes or no? If there was waste, was it co-signed, yes or no? And were all vials being used single use? Believe it or not, I've been in facilities as close back as a couple months ago. I was looking through the anesthesia count sheets, and I saw splitting of fentanyl vials between patients, which fentanyl, number one, is a single dose drug, and number two, the risk of a lot of problems when you're splitting these vials in the OR is enforceable. So this is a tool that we use quite frequently, and these audits are performed by the staff and also by the pharmacists, their inspections at the facility level. So what kind of security measures can be put in place? Our benchmarking study showed some of the best practices that are out there. Are we secure, and are we making sure that the narcotics are not accessible by someone not able to access them? Is video surveillance something you're using in your facility? We're seeing more and more video surveillance at the narcotic cabinet for further protection. Did you ever think about maybe getting pre-filled syringes from our FDA approved compounders out there now that are tamper evident and tamper proof? Multi-person audits. Again, audit tools are available to be performed. Proper wastage signatures. I had nurses come up to me and say, John, you know, at the end of the day, this certain anesthesia staff member wants me to sign my name 5 times for all his wastage today, and I didn't see it. You really can't allow nurses and their RN licenses to begin signing for waste if they didn't witness waste, and you shouldn't have anyone performing waste without having a signature to watch them waste this narcotic in your building. You know, a lot of security measures are listed here. Certainly, when we do a risk analysis at the facility level, we are going to look at making recommendations to further enhance your process. Again, video surveillance comes in many ways, from motion activated sensors to continuous feed to off-hour video. Sometimes you can watch them live on your cell phone if there's been movement in that area. All things that have been shown to demonstrate in our fields and on our investigations at centers with diversion helped us identify where the problem was. So proper disposal is strategy 7. Again, how we waste narcotics at the end of the day or at the end of a procedure is important. The DEA states now that they must be non-retrievable, either by chemical digestion agent or incineration. The days of shooting them in the trash or other forms of chemical or products to waste narcotics is not acceptable according to the DEA. And reverse distributors for disposing of your expired narcotics is something that is required in some of our states, can be used in all the states to properly dispose of your narcotics that go expired in your facility. And again, just a little strategy for wasting expired meds, narcotic waste, narcotic products in your facility. Take a look and see if you need help with wasted procedures. So again, I always have a message for my facilities. If we're not moving forward, we're falling back. And with technology, whether it be pre-filled syringes for consistency, for labeling, for tamper-evident safety caps, it really beats the lower picture of syringes left on a cart that we don't know if they were entered, we don't know if they were tampered with. So certainly look at 503B compounders and the opportunities to further safeguard your drugs in your facility. We actually go out and vet the 503Bs. We have currently 4 or 5 compounders that we've vetted around the country and feel very good and very strong about their quality and products being distributed through them. Let's talk about education for our patients. You know, when our patients go home with prescriptions, are we talking to them about the dangers of leaving those drugs in their medicine cabinet? Are we making sure that we give them proper training on the use of their pain medications? You know, we call it the friends and family discount when a medication is put into your medicine cabinet or a patient's medicine cabinet back at home after they've done treating their post-op pain. A family member can get their hands on it. And, you know, we were just talking before the talk today about these parties that kids have where pills are brought in from parents' medicine cabinets. In certain states, we are wanting to make sure they know where the drug disposal take-back centers are. And in New Jersey, the Division of Consumer Affairs makes posters for medication disposal, and it is the law in New Jersey that every prescriber that writes for narcotics has to educate the patient on proper disposal of those narcotics after they're done using their medications for their pain management and not leaving them in their medicine cabinet. So we want to coach our patients. Maybe we can have this scripted. Maybe at your PACU, you can have your nurses in discharge teaching have some scripted questions. Where are you going to be storing the drugs? Who has access to those drugs? What will the patient be doing when they're finished? Don't just keep them in your household. And tell about the drop-off centers. Every state throughout the country has DEA drop can be disposed of. And I think that's the end of the program. If you have any questions or you have any comments, please bring them up. I think Andrew's going to field some right now, and maybe I can answer a few while time remains.
Sure, great, John. Thank you. That was very practical and very interesting. I know some people have mentioned that the audio was breaking up, but I think everything came through. So while people are putting in questions, let me throw some out at you, John. So you have a lot about the wasting logs. Why, in your kind of opinion, why do ASCs struggle so much with getting this right? You know, they're always getting cited. It's always the source of so many problems. If you had to kind of pick your top 1 or 2 reasons, why is it so hard?
Well, I think that sometimes you're dealing with individuals seeing different practices at different facilities. Not everybody's working at the same center, and different centers going from hospitals to surgery centers, different products for wastage are being utilized, different bins. If the location of the receptacle where you have to waste the narcotic is not close to where you're wasting your syringe, it's not going to be used. The other thing that I think is education for contracted services. I was in a facility where a surveyor asked the anesthesiologist, where do you waste your fentanyl after you administer a partial dose? He had the proper receptacle on the counter, and he said, oh, I just shoot it in the trash can. Well, he was never trained on the proper receptacle for wasting narcotics. So education and proper direction at your facility is very important to maintain compliance with wastage.
Great. And, you know, almost all states now have various websites that need to be checked before you prescribe. can you speak to the role of the ASC in making sure that gets done? Do they have a role?
They don't have a role. The regulations speak to the responsibility of the practitioner or his or her designee. And if a ASC wanted to offer their assistance to the practitioner for looking up a patient in that database, they could certainly do that. But there is no law requiring the ASC. It is basically the prescriber writing the prescription. Responsibility to look up that patient's history. So the pharmacist at the pharmacy where the prescription is going to also has a responsibility of looking up the patient's history and the prescriber's history. So the ASC is free from any requirements there.
So let's say a doctor comes to the ASC administrator or the medical director and says, you know, we looked up Andrew Bluestein and he's an abuser. I know you mentioned in the slides about having agreements with patients. I mean, if you see somebody's got a checkered red flag, as you say it, on their report from the websites, can you still prescribe, or is that just, no, you can't do it?
Well, I believe each state might have different rules for prescribers I know that they certainly have programs where that patient gets referred to a pain specialist. And Joint Commission is actually coming up with standards for 2019 requiring hospitals and health facilities to identify drug abusers and recommend treatment programs to these individuals. Again, if it interferes with the care of the patient before a surgical procedure and it is a risk to do surgery on a drug abuser, and we see this more and more with chronic pain management patients coming in for a separate type of surgery. It's a big challenge for the providers, for the anesthesiologists, and for their nurses to not run into problems with this patient during the care at their center. But again, Joint Commission is working hard on developing standards that everyone will be identifying these patients and making recommendations consistently across the board.
Right, and I just would add, given that we're also going to actually put this recording on the New York Metro's website, somebody listening to this may be themselves having an addiction problem. I would just say, as a follow-up to your comment, having represented physicians and nurses and people who have had problems, putting yourself voluntarily into one of those programs that's sponsored by typically, your society can really go a long way to you preserving your license. Okay, so we've got a lot of questions about urine testing. Now, when you mentioned that before, were you talking about urine testing of patients or employees?
Employees. I was talking about employees. We want to really recommend that each ASC has their policy clear to when testing of an employee suspected of diversion should take place and who and how should that take place. Okay. It is really across the board right now from center to center on the practice of urine testing for suspected employees suspected of diversion.
So, okay, so let's stay with that. Am I checking all employees or just those that are suspected? And as a follow-up to that, somebody asked, what's the point of urine testing if I haven't injected the drug, it's just sitting in my pocket?
Sure. Well, first of all, it's going to come down to the governing board's decision whether everyone in the facility, every employee would be required to be tested. I gave an example of one center that diversion occurred and everybody was required to give a urine sample. Other centers, I've been involved with diversion and no one's been tested. I've been with other centers where the recommendation from the legal department was that the individual suspected of diversion was asked to do a urine test. So it really is, there's no standard. It would really come back down to what you feel comfortable with as far as your legal department's recommendations. Secondly, the question of if you test someone's urine and it's just the vial in their pocket, definitely that will come back negative. Urine testing, by the way, for opioids is not 100% accurate. We just think that it might be another opportunity to, if it did come back positive, then that is a certain conclusive way of telling if drug is in someone's blood, is someone in their body. If it came back negative, it doesn't rule out that they still didn't steal drugs, because it still might be in their purse, in their pocketbook, but it is certainly within the repertoire of an administrator to have in the event diversion is suspected.
Right. Okay. I'll answer the next one, actually. Unless you disagree with my answer, let me know, and then I'll throw another question. Can a center search my person? So I think that goes to what John was saying before. We've drafted a lot of these policies, I'm sure John has also. If a policy says that you can go up to somebody and ask them to empty their pockets, and if they refuse, it's grounds for termination. You can do that. You can't just take somebody and hold them down and search them, but it can be terminable if they don't voluntarily do it. So you have to have a policy that deals with all of those, including testing. Okay,
correct.
Next question.
I think that's a very good point in having everything at your disposal. I wanted to follow up with the urine testing. We found that sometimes just the threat of urine testing of a suspected diverter has the ability for that person to offer up a confession. So don't rule that out as an opportunity to get someone to confess just by the notion of we're going to be launching urine testing. The other thing with checking someone's personal belongings, that might fall back into your employee handbook and what it says on hire you are allowed to do and what you aren't allowed to do. That's why I always talk about, before we take steps in this activity, have a strong policy approved by the governing body or your legal department on what you can and what you can't do, because you may miss an opportunity to do something very important to catch diversion when you are not sure of what you can and what you can't do.
Yeah, I totally agree. And so many ASCs, little off topic, are not looking at their handbook, or it's the handbook that the management company gave to them like 6 years ago. It's completely outdated. It may not be specific to the state you're in. So feel free to call if that's something you need. Okay, next one. There's a good question. Are centers responsible for showing proof that the physician partners, I guess, of the center are educating their patients about how to destroy or dispose of unused narcotics? John?
Great question. Again, if it's not written down, you didn't do it. The old adage, maybe if you're having a physician educate a patient on drug disposal areas, that maybe there's a checkoff box in the chart, or maybe there's a sheet. You know, what I've seen is that handout from New Jersey Consumer Affairs. One goes to the patient, one goes in the chart. So now the chart note, the patient, you know, in retrospect, if you open that chart, you're going to know that someone talked to that patient about the drug take-back program. So that you should not rule out ensuring if you're having a physician educate the patient.
Yeah, and I also would say that, you know, ASCs, unfortunately, are more and more in this role. It's not that you're responsible. I would look at it from, you could be helping your physicians, because so many physicians just don't know about this requirement that they have. And so by helping them and putting kind of those tools in their hands, it's value added. And, you know, as soon as they realize that they can get into hot water by not doing it, they should do it. Okay, here's another one. I'm not sure I understand it, but maybe you do. Is it a good idea to have the, is it a good idea to have the RN and CRNA do the morning count and the distribution of the meds at the same time, or should there be two RN staff to count and then the CRNA can sign off on reviewing drugs?
Great question. It's a really good question. It comes up a lot. My stance for ASCs is the anesthesia department is a contracted service. I would say employees of the facility should perform the morning count. Now, when the anesthesiologist or CRNA come for their supply for their room, they would be signing, and the nurse issuing their supply for the day should be signing, so that they both agree that they left the narc cabinet with the amount on the sheet. But the morning count, if possible, again, remember, Andrew, we got centers that might be very short-staffed, and we don't have two nurses to do the AM count all the time. It might be a small facility. I'm not in opposition of 2 licensed personnel signing off to do the count, but they have to be there together. I had a situation where we had diversion, and we found out after interviewing that at 6 a.m. when the nurse arrived, she did the count, and then at 6:15 when the anesthesiologist came in, the nurse said, "Oh, I did the count, just sign your name." So whoever does the count has to be done in person with 2 people, and they both sign together. The preferable way is 2 employees of the surgery center, but it is not out of the question that due to staffing problems, you can have the anesthesia department and the nursing department do the morning count.
Okay, great. Last question, and then we'll follow up with some closing thoughts. The video surveillance issue comes up a lot, and how would you respond to employees who say, "Hey, it makes me nervous," and another thing employees will say is, "We don't think this is conducive to patient privacy," and those kinds of issues?
Sure. Great. Again, excellent questions by our guests today and our audience. We have begun seeing more and more video surveillance. The cameras directed directly over top of the narcotic cabinet or in a medication room. We do not recommend video surveillance anywhere where a patient may be put on camera. So if you're looking at video surveillance, it would be not directed at any patient area. It would be strictly at a narcotic area. The main cabinet is where we see it. We do recommend the cameras. They do have a good track record. I think whenever something is new and there is a change, staff may feel intimidated. That, I believe, will fade off, because that's what your facility requires for security purposes and education on why you're doing it. I always am a big fan of educating staff on why something is being done. Whether you tell a person every day you have to check the refrigerator temperature and just write the number down, and that sets them up for failure, because if it's out of range, they weren't even told what to do. To why we're putting surveillance cameras in over the narc box, it's to protect them. What's going to be caught? What's going to be caught on there? They shouldn't be worried about it at all. It really is an education thing, and over time, I believe that they feel better, because now, if anybody was diverting, it's going to be caught and be able to be viewed, and our patients are safer for it.
Yeah, and I would also tell you, I had an ASC that had a camera, but over the years, they stopped paying the company that was recording it, right? So there was a suspected diversion. I truly believe that the person suspected, I don't know why, just on instinct and her tears, I believe that she didn't do it, but she was in the wrong place, probably at the wrong time. But we couldn't exonerate her because we didn't have the tape. Ultimately, I think we found out it was somebody else. But I would also say to the employees, unless you're a planned diverter, you should view this as positive. Well, I mean, what are they going to see? That you didn't wash your hands when you came out of the bathroom? I mean, whatever. But if you're not diverting, I would want everything recorded so no one can accuse me of diverting.
Absolutely, so Andrew. That's how I present it. We're not watching you. We're not putting the camera at the lunchroom where you're eating and doing anything. It's just making sure that our drugs are secure and our patients are safe. Right.
So a question came in about offering CEU credits for this presentation. Not yet, because if you go to the slide, first of all, if you want to contact John with questions, Obviously, there's his contact information. If you want to reach me, it's also at the back. But if you look at the slide about our ASC seminar, we are having credits pending. So we don't have them yet, but we hope to get them. So nothing for this one yet. I don't know if we can do it retroactively, but again, for those of you who joined late, there is a discount code if you want to register for the seminar, because then you will get credits, and there's going to be a lot more of this kind of information, and John will be there as well. It's NYM18W, and you can get on NewYorkMetroASC.com. That's NYMetroASC.com. And over the next 48 hours, that code will work. So today's Thursday. I think it goes out Saturday afternoon. So thank you. I think, and I see people are chiming in, this was a great presentation. I agree. John, you were very practical and insightful. And we'll see everybody on November 2nd. And we're also going to be doing some more webinars. So if you, leading up to November 2nd, we have some really other great topics coming up. So if you have registered today, you will be getting those announcements, and they're always free. It's just a service to educate people. So thanks to everyone, and register. And John, God bless, and we'll be in touch.
Thanks, Andrew. Thanks, everyone. Bye-bye.